Good evening. Welcome to Feet Forward with the Illinois Podiatric Medical Association. My name is Chris Martin. I'm here with podiatrist from Naperville, Lawrence Kosova.
Kosova, correct.
I've been practicing that in the green room. It's been a couple of months since we've been here, since December, but we've been busy working with CAN TV on special promotions. Some of you who were kind enough to tune in to the call-in show we had in January, we appreciate your calls. We got a robust response from our 30-minute promotional video that we did here with CAN TV, and much thanks to the staff here for putting together a first-rate production. I know you were part of that too.
It was really stellar program. We got a lot of calls coming in, and I think we helped a lot of people getting them to the right, doctors, the podiatrists that they needed to help their foot problems.
Yep, we're all about helping people with foot problems here, and we are taking your calls today. The number's right there, 738-1060. Dr. Kosova will be happy to answer any of your calls, even if it's not about flat feet, which is what we're going to talk about tonight. 2 weeks ago, the biggest meeting of podiatrists and the podiatric medical profession was held here in Chicago, as it usually is in the spring. And one of the interesting things I thought about the meeting was there were so many presentations. I think there were 5 sessions of various sizes, with experts and presenters and research and case studies on flat feet. And I talked to some of the presenters and asked them why it is that this is such a topic that's on the profession's mind. And there still seems to be, the feedback I got from many of the presenters, who came from all over the world, including one woman from Australia, that there still isn't an overwhelming consensus on this disorder, and that it's still treated with a wide spectrum of techniques, approaches, philosophies. And so one of the things that I want to accomplish on this issue, this edition of Feet Forward, is to sort of talk about some of those differing viewpoints, give the viewers some tips on how to navigate through this if either they have flat feet or the sort of byproducts of flat feet, excuse me. Sorry, this isn't a weight loss show. Or if they have, or more importantly, if any of their children have some of the symptoms, and we'll talk about some of those as well too. But why don't we kick off by if you could just sort of give me a little overview of the show, the meeting, from what you were able to take in. I know you took in one of the flat feet sessions, and tell the viewers if that's sort of your take on things too, and how you feel about it too.
Well, the whole discussion of flat feet is, depending on who you're talking to, there's definitely different opinions. And we really have to kind of segment it from if we're talking about children or adult, because there's actually 2 different subsets of flat feet. So, like I tell my own patients, is basically when you're looking at when a child, if they're 2 or 3 years old, they're commonly always flat. So that's not really a flat foot condition. We want to know what happens beyond 3 or 4 years, going into like the 5th year, of what's going on with that arch. Now, if a child is just having a low arch in their foot, but yet they have no pain symptoms, they're running around, they're playing with their friends, they're having a good time, that's not what we consider pathological flat feet. That's just somebody with a low arch, and there is a normal condition with children and adults. They have low arches, not a problem. But when it becomes a condition that becomes actually painful to the patient, and I have 10, 11-year-olds that actually have early arthritis in their bones due to having the flatness of their foot. They can't go for long walks. The common thing is that I hear from patients' parents all the time is that, my child is lazy. We go to the supermarket and he has to always sit down, or he doesn't want to play at school or in gym class. And now we're getting into a condition that is more pathologic. There's usually pain symptoms associated with it. And that's really the condition that we're looking to try to relieve for that child.
One of the things I heard from one of the doctors was with younger kids, they don't often express symptoms of pain as much as older kids or adults because of communication issues.
It's a great point that you're making. One thing that I usually go right to the children in front of their parents, I'll usually say something like, can you tell us what it feels like every day for you? And a lot of these children, they're born with a flat foot. They've lived through, 4, 5, 6 years with it. They don't know how to express that if a condition is actually painful. So, I'll kind of lead them a little bit and say, tell us what you're feeling every day. And it really comes out. You see these 6, 7, 8, 9-year-olds telling their parents in front of me, I thought that pain was normal. I thought everyone had this. And that's why it's such a little misnomer about how to go about treating it, because children don't really express that. If they don't step on something, a toy or a nail or something, and really feel that intense pain, and they live with it their whole life, it's normal for them, even though it could be a pathological problem.
And that's where we see the beginning of an over-tolerance of pain in adulthood, too, where some people just feel like, well, my feet have always hurt, and that's just the way it is, when we know that pain is not something that should be tolerated in feet. It's not acceptable.
Pain in medicine in general shouldn't be tolerated. I mean, anytime you have a painful situation, it's abnormal. I mean, it's not normal for people to walk around and have pain. So, especially with adults, if they had flat feet when they're a child and they kind of live through it, when you go back to that adult now, I have patients now that I talk to their parents, their mother and their father, and they always go back to, having pain at nighttime and having pain having to walk and not having the proper shoes or wearing out their shoes, which is very common on the inside of the shoe.
Right.
You just constantly hear these things coming back. I hear from them, I don't want my child going through that.
Now, you were kind enough to bring a couple pictures of what flat feet look like. But before we get in that, why don't you just run down a couple of the more obvious symptoms that you've noticed over time, with especially focusing on kids. We could talk about adults too, because you brought some x-rays of some different treatments there too. But talk about some obvious signs that parents can look for to determine whether their child might have flat feet, and whether that might then spur a conversation with their podiatrist or with their pediatrician.
Well, one thing why you brought up the pediatrician, a lot of times this gets overlooked by the pediatrician. In fact, our own daughter's problem got overlooked by our pediatrician, and her child actually was the same age, same first name, by the way, and had the same condition. And until we did something with our child, it wasn't flatfoot, it was another condition, she decided to do the same thing with her. So sometimes the pediatricians, they mean good, but sometimes they overlook this because this isn't a, quote, serious problem for them. And they're usually getting the kids really kind of early. But with most parents that we tell them, it's really the symptoms coming from the child. If the child, is starting to have pain and expressing that pain, Mom, my leg hurts, my foot hurts, because sometimes it's the leg that'll hurt, or it's the knee. We have a lot of children, 5, 6, 7, 8 years old, that have medial knee pain, or they'll have hip pain. That's not normal for a child.
Right.
So sometimes it's not really just coming from the foot. It's other elements that could actually be causing that. The other thing is looking at the arch, seeing if the foot is turning in. I have a model here, and the one thing that we want to see is that this portion of the foot is coming down. And a lot of times when the patient is walking, they're almost walking on this ankle bone. And that's very common to see just from what we call a neutral stance, just having the child just stand. And you start seeing the arch completely fall. Now that in itself can be normal flat foot, but yet if they start having pain going up the leg, there's a tendon here usually, but going up the leg, and they're complaining about pain on this side, or actually even pain in the heel, very abnormal for a young child.
And we're going to show a picture here that demonstrates one of the ways parents can actually help determine whether their child has flat feet. If you get down on your knees, like your photographer at your office, we'll show you this picture. Right, there we go.
Yeah, the one on the right was corrected with a stent that we did. And if you look on the inside of the arch, just where your finger was at,
right here,
perfectly, you could see that that's a nicely formed arch. And this is after the surgical procedure, approximately about 1 month. And if you go on the opposite side, you could see at that portion that there's no arch. And if you go up just a little bit, you see a big bulge on the inside. Right, both of them.
Both of them.
That is actually what we call the talar navicular joint. actually dislocating. And on one of the x-rays, we actually show that dislocation to actually help diagnose whether this is quote-unquote normal flat foot or pathologic.
So that's an easy way for parents. They can have their kids take off their feet, their shoes and socks, and you can get down your hands and knees and actually look at their feet from behind the heel.
Correct. That's one way. And of course, watching them walk, sometimes what we call gait, or the way that they walk, their feet can actually turn outward and sometimes can actually turn inward. Too much of either is actually not normal. Mm-hmm. So just watching your child, and some of the problem is that we have parents that they have their first child, or only have one child, and they really don't know what normal versus abnormal is. It's usually when they get to that second child that they actually have a lot more knowledge.
I'm a middle child, of course, too, so that's how it turned out so well. Thanks, sisters. So once the parents and podiatrists have come together and made a diagnosis, what then? Does it depend on age and other kinds of factors too?
Well, yeah. I mean, like I said before, when a child usually starts walking between 9 and, let's say, 16, 17 months. So at that time, their arches and their muscles around the arches aren't really developed yet, and their bones aren't fully developed at any means at that point. So most children look flat at that point. It's really later on in life, 4, 5, 6 years, that you want to start seeing an arch form, and you want to see that there is some continuity of what we call the medial arch of the foot. But again, just having a flat foot does not mean that there's a problem that needs to be fixed. Again, later on, sometimes the patient can actually have night pain. Their calf can actually be very sore, and a lot of these kids wake up and actually they're crying or screaming in the middle of the night due to the calf muscle being very tight, which can actually lead to some flat feet conditions. So it's not just all this arch that we're looking at. There's definitely other things that we're looking that can contribute to that.
So when you get one of these patients, then you're looking at making a decision on treatment options. And this is, again, one of the things that came out of the meeting was there's this fairly large spectrum from conservative, watchful waiting to sort of a minimally invasive surgical procedure and a couple things in between. So maybe you could talk a little bit about that spectrum and when is it appropriate for a conservative approach, and when would you recommend sort of an intervention of some kind?
Whenever you're dealing with anybody, whether it's a child or an adult, you always want to try conservative treatment first. So there is a theory with most children that they want to start conservative first. So, I mean, we have things like the orthotic that I have here that's showing that a medial arch, and this is something that's prescribed by a podiatrist, and we write a prescription. We size the patient up, and we make this for them. So the question is whether putting a child, there's a big theory out there to put a child into an orthotic for 2 years and then have them back, or just watch them, every 6 months and then see if their symptoms improve. Now, with anybody, if their symptoms improve, then there's really no need for surgical intervention. The question is, what are we really doing? Are we actually correcting the problem, or are we just prolonging the problem to show up later on in life? And that's really where the controversy comes in.
Is that orthotic, can it be worn in every pair of shoes that the child wears, or are there certain orthotics that work better for some shoes?
Mostly for children, like what I just showed you, what we call a dress orthotic, but we would make more of like an athletic orthotic that would fit into most of the shoes that a child's going to wear. And let's face it, most children are going to be in some sort of sneaker or soft shoe, so it's pretty easy to get one orthotic to accommodate most of their shoes.
A lot of kids just wear the same shoe until they wear them out, and they just buy new shoes, right?
Yeah, and the important part about that is, as we're talking about things for parents to look for, is look at the backs of the shoes, put them on a table, and seeing if there's a wear pattern. In other words, on the inside of the shoe, are they wearing it down? You can actually flip the shoe over and kind of look at the rubber on the bottom. Is it worn down more on one side versus the other? And these are just little subtle things that a parent can do to kind of evaluate what's going on. It's something that we actually do as part of the whole diagnosis process.
Now, in your experience, you when you have patients that come back after a 2-year treatment with orthotics, what have you noticed about them? What percentage get better? And
that's the hard part. It's hard to talk about percentages, but some of the patients might do mildly better. honestly, in my opinion, I don't think really an orthotic for somebody who has pathological flat foot is really doing a lot for that child. And there's the controversy. On one of the x-rays that I have there, I show you that there's actually a dislocation
Which one's
of...
the best one?
No, it's the other one right there. But there's actually a dislocation of this joint right up in here, called the talonavicular joint.
That's right here?
Correct.
Am I on the right foot here?
It's the correct foot.
This foot here, okay.
Yeah. Either one. You could,
Say
you
that,
could go to either one. So if you actually turn it a little bit, sorry that we're having a little difficulty, I would turn so the toes are that way, and we could show it easier. Yes.
Gotcha.
So what we're looking for, so what we're looking at is basically right in here, this bone to this bone, if there was the center of it, would be right here. Mm-hmm. And this is literally going outside of the foot. We actually want this bone to go straight up the big toe. Mm-hmm. So if we take, we have another, this one right here. Yeah. So if we take, in this case, we're using an implant, and if we take this to actually correct it, we see now that this bone is going directly up the big toe. It's not coming down on the side and actually corrects the flat foot. And that's one procedure. It's a very easy procedure, about 15-20 minutes to do for a child. Mm-hmm. Not really invasive. It's done through a very small incision. And the nice thing is, if the child doesn't tolerate it, or if there's an issue with having an implant in, it's very easy to remove, and it's really not doing much harm for that child. So it's a very easy procedure for most children to tolerate.
Was that actually the same feet as the picture that we showed earlier?
It's the exact person. So, you get dramatic changes, and what I showed you was about 3.5 weeks down the line.
After the surgery?
After surgery. So as that child actually grows and matures over the next couple months, there's going to be more of an arch, and there's going to be more of decrease of having the symptoms that they came in with. Usually it's pretty immediate.
One of the things that we learned from the meeting a couple weeks ago was the importance of evaluation. Perhaps intervention isn't called for every child and every circumstance, but an evaluation when a parent sees these kinds of signs and symptoms is important, because these problems do come home to roost when people get older, and they take the form of a lot of different kinds of problems, don't they?
Yeah, I mean, right now I'm actually treating several patients that had flat foot as a child. They're adults now, between 45 and 55, and each one of them actually tore the tendon that goes to the arch to hold it up, and they actually stretched out the tendon so far that it actually tore or ruptured. So there's actually a direct correlation between having flat feet and later on in life some of the problems that you could run into. So in those cases, we're actually, repairing the tendon and actually putting an implant like this in to actually help correct that flat foot so they don't go on to re-tear it, is really what it comes down to.
And what kind of surgery is that?
It's a little bit more invasive, and it's not as easy as what we were describing before, but these are adults that we're dealing with. They've already adapted. They're flat foot. Children are really easy. They're sort of like Play-Doh. But adults actually adapt their problems, and it gets a little bit more complicated.
So you'd shown the x-ray where, let me just put this back up again, where there was the surgery and the implant done. You can see it right here. Mm-hmm. And then right here.
Correct.
Talk a little bit about that procedure. I think we went into a little bit of detail last year when you were on, but since we're talking about flat feet, and this is a flat feet specific sort of procedure, why don't you talk a little bit about that and give the viewers a sense of how this procedure actually works?
Well, it's done through a really small incision. Incision is probably about, let's say, an inch and a half, or what have you. We locate the area. This is called the subtalar joint. We actually locate that area. And this is the actual implant. It's pretty small. And once we actually locate the area and find the proper size of the implant, then we really just go ahead and put it in. Mm-hmm. And it's a little bit more difficult than what I just did, but it's pretty much that easy also. So, and we go through, in surgery, we actually have what we call live x-ray, fluoroscopy, and we actually use different sizes to see what the appropriate amount of correction is. And the nice thing about these types of procedures is that you could actually see the correction right there. So you know how much you need or how much you don't need, and you can dial it up or dial it down depending on what you actually need to accomplish for that patient.
And what is the net effect in terms of the biomechanics of the foot of that implant when it's inserted? What does it do for the foot then?
Well, at that point, what we're doing is that segment of the bone that I was showing you before, how it was actually collapsing, we're actually not allowing it to collapse anymore. So it actually holds up. And the tendon that we were speaking about with adults that tends to rupture quite frequently with these flat foot patients actually doesn't have that same pull anymore, because what they had before was a very abnormal pull. So now it becomes a more normal pull, and they don't go on to actually stretch or rupture that tendon. The foot itself is dramatic. I mean, 5 days later when we have patients come back to the office, we actually will see, instead of having their heel collapse totally, we're actually seeing the heel actually straight. And it's always very dramatic for the parents. They're always very excited to see that on their child.
And how many of these procedures have you done over the course of the last few years?
I've been performing this for about 20 years, and I don't really have a standard count. In the last couple months, we've probably performed 7 or 8, which is a lot, and both on adults and children.
And this is a commonly performed procedure in the Chicago area, right? And throughout the country?
If you're trained. Not everyone is trained in this. Not every podiatrist or orthopedic surgeon actually does this procedure. This is a specialty amongst itself.
Yeah. What else? When the screw is inserted, how does it stay sort of strong and sturdy in there so quickly after the surgery is done? Doesn't it take time for the tissue to heal around it?
Yeah, even though it looks like a screw, it really isn't a screw, number one. But number two is that after it's inserted, the tissues around it actually will adhere to it and actually help stabilize it. There are consequences also. I mean, these implants can actually dislodge if a patient falls right after surgery or a couple of weeks into it. So we need to protect that patient also. On children, we tend to actually have them walk pretty quickly after surgery, about 1 to 2 weeks after. Adults, we actually go a little bit longer. It takes longer for an adult to actually adapt to these types of implants, again, just because all their tissues have adapted over time.
And how long does that take for someone to remain or to regain normal activity? If it's a child, how long before they can be active in sports, for instance, or if it's an adult, how long can they get back to working out or performing the golf or tennis, let's say?
I would say about 3 months, to be fair. I mean, I had a child that we just did a month ago, and she's mad at me because she wanted to go rollerblading 3.5 weeks afterwards, and she was running up and down my hall. Everyone's a little bit different. Some children take longer than that. Some children, basically, in adults, actually can respond rather quickly. So we don't set a timetable. We actually go on what that patient actually needs.
Just because you're running up and down the hall doesn't mean you're ready for rollerblading. Is that what you're saying?
Well, I didn't want her to dislodge it. We're actually doing her other foot in about 2 weeks, and I didn't want her hurting her opposite foot. I think she was fine with the one with the implant.
You don't recommend having both feet done at the same time, then?
It can be done. It depends on the activity of the child. Like if you're doing it over like a summer vacation and they're not going to be really active, I would go against it for most children or adults, but it can actually be done.
Okay, great. Well, this has been a very interesting session. We've covered a lot of ground. For those of you who are interested in finding a podiatric physician, you can call the 800 number at the Illinois Podiatric Medical Association right on the screen here. That's 888-869-3338, or go to our website at ipma.net, or you can find us on Facebook. That's facebook.com/Illinois Podiatric Medical Association. Somebody will be staffing all those phones, websites, to get back to you and provide you with a list of podiatric physicians in your area. Next month we'll be here again, and we're looking forward to talking to you. Until then, thanks to you from the Illinois Podiatric Medical Association. Thanks to you, Dr. Kosova.
My appreciation.
And we will see you next month.